Good morning, everyone. Good afternoon, good evening, wherever you are. My name is Magda Sanz-Cortez. I'm a fetal surgeon here at Texas Children's Hospital and Baylor College of Medicine, and it is my pleasure to introduce you to this first webinar of this series of free webinars that we have organized covering different topics on fetal surgery. The objectives of these webinars will be to have very concise and precise information about what's the current status of the evidence on different matters that affect fetal surgery, and also to make sure that everyone who's attending to these webinars, that I'm sure that you have a strong interest in this field, get very clear concepts that can be applicable to your clinical management and to your clinical practice. Today, we have a fantastic panel. We're very grateful for our guests, Professor Veal, Dr. Steinerman, Dr. Miller, and Dr. Shamsirsaz, and myself as the host and hostess of this webinar. We're very excited to have this opportunity. So I'm going to let Dr. Shamsirsaz introduce our first talk today.
Good morning, colleagues. Again, good afternoon, good evening, wherever you are in the world. Welcome to our first series of the fetal webinar. And I'm honored to introduce the first speakers, Dr. Professor Eve. He is a chairman of the Department of Obstetric and Fetal Medicine at Necker Hospital at the Paris University. He's one of the giants in the field of the fetal medicine, and he's well known for his contribution to the management of the monochorionic diamniotic twins and twin-twin transfusion and laser. He had more than 600 publication, and I'm pretty sure that all of you are familiar with his work. With that said, we can start his talk.
Hello, good morning, evening, or good night to everyone. Thank you, Magda, and thank you, Michael, for inviting me to speak about the future. It's very flattering as time goes by. So thank you. The future of fetoscopic surgery in twin-to-twin transfusion syndrome. Well, to speak about the future, let's have a quick look at the current state. The current expectation with surgery is to reach roughly between 70 and 90% survival in terms of twins alive at birth or discharge, and increasing the proportion of double survival has always been the aim. So if we look at the mean gestational age at birth, it's been sort of stagnant at around 32, 33 weeks. So that shows that at the moment, this surgery is dedicated to centers that can cope with severe prematurity and potentially some rare but severe maternal complications. The brief history of that, starting in the late 80s, where the diagnosis of twin-twin transfusion was recognized on ultrasound in utero. Then the very beginning of fetoscopy in the mid-90s put an end to serial amnioreduction, and it took a few years getting to a randomized controlled trial published in the New England Journal of Medicine in 2003, and that was the beginning for the wide acceptance and dissemination of the technique that has proven reproducible in different centers using roughly the same equipment, which is to use a fetoscope that gets into the uterus through a trocar of between 2 and 3.5 millimeter, depending on the size of the endoscope. I will leave aside the mild improvements that can be done in endoscopes, because I think we've reached a quite a good and satisfactory level of technology on that side. In the early 2000s, the recognition, characterization of a post-operative complication known as twin of TAPS, which is anemia polycythemia sequence, whereby the former recipient bleeds into the former donor through a single, usually left anastomosis behind fetoscopy and laser coagulation. That has led to a lot of thinking coming back from a completely selective technique that has succeeded to a non-selective technique, which was to coagulate the whole length alongside the intertwin membranes, to come back to a more radical coagulation of the placenta surface that is known as the Solomon technique, although the Solomon judgment was meant to kill both babies. This one was meant to save both babies. But nevertheless, the Solomon technique, which is to join the dots by blind coagulation of the placental surface in between the very selective coagulation of identified anastomosis, draws a continuous line of burning of the chorionic plate and the membranes. I insist on that, and we come back to rupture of membranes later on. And then finally, the issue of stage 1, which I will allude briefly in another couple of slides, of what to do with stage 1, which is the sort of mildest symptomatic form of TTTS. I careful to say mildest symptomatic and not mildest disease of twin-to-twin transfusion syndrome, whether we should operate or wait for further degradation of the fetal or maternal tolerance. And that was in 2019, it's been published last year, and I will summarize that briefly. So the current challenge, or the future challenges, they are current, but they may be left for the future, is to still improve survival, if at all possible, is to decrease the iatrogenicity mainly of surgery, and that means for the vast majority of them, they are rupture of membranes related. So let's look through that. So improve survival. Well, that needs to address a few well-identified issues here. Quintero staging, gestational age at surgery, cervical length, and the severity of donor's growth restriction, the estimated fetal weight in relation to the recipients, and the abnormal umbilical artery when the donor is severely growth restricted. I will leave this one aside because it is a dream rather than a real prospect. We can't do much about this, and we can't think of much about this. Let's concentrate on the three factors that we may have an impact on with a bit more work. Quintero staging, I remind all of you, but you're all specialists. This is the roughest, not to say simplistic classification. Roughly stage 1 and 2, it's a matter of plumbing with polyhydramnios, oligohydramnios. In stage 1, the one that should not produce much urine still shows a bladder. And in stage 2, this is the full picture with an absent bladder, at least absence of visibility of the bladder in the donor twin. But the Doppler are normal, and usually growth is roughly normal, at least with normal Doppler. Well, stage 3 is a different disease. Mainly it's growth restriction with abnormal Doppler in usually the donor, and still the poly-oligo sequence. And stage 4 is cardiac insufficiency in at least one of the twins with hydrops. Usually hydrops due to cardiac insufficiency and not to anemia. When there is anemia, then it's a combination of TAPS and TTTS, but that's something else. It's about 3% only on the cases. Well, if you look at that, it's not obvious that there is a continuity, of course, between 1, 2, 3, and 4, although 4 rarely arrives as the first presentation. Usually it develops when the first stages have been neglected, but it can go from stage 2 to stage 4. You can go from stage 3 to stage 4, but you rarely go from stage 1 or 2 to stage 3 unless you see some premise of TTTS in the first trimester of pregnancy, but that's not the most common presentation. So this is for the staging, and although this is rough and simplistic, there is a relation between survival and the stage at which TTTS presents for diagnosis and management, and roughly the prognosis is better in stage 1 and 2, which were mixed together in the first randomized trial that shows the superiority of laser over amnioreduction. And there's been much controversy for years about if stage 1 could be left alone until, under heightened surveillance and not operate to avoid the iatrogenicity of surgery. And we've done this randomized trial that was published last year in AJOG, and you can see that the overall survival is not different whether you wait before you operate, therefore you wait to go from stage 1 to roughly stage 2 or 4, or if you operate straight away within 48 hours. Overall, there is no difference. However, the important one is about PROM, a rupture of membranes before 32 weeks, which are the ones that really matter. And this was threefold higher in the group that you operate straight away. And what you see also is that if you wait, then you will eventually, in 40% of the cases, the situation will be stable. And what you will increase also is the proportion of double survival. What we showed also is that if you wait and if you are in the position to operate in as a secondary approach, then the success of the surgery and the consequences of the surgery will be the same as if you operate on the first place. So definitely between operating and not operating, there's a difference in iatrogenicity, and there is in terms of rupture of membranes and in terms of losing one twin. And that is in stage 1. So that leads us to looking at PROM. PROM, which is the real Achilles heel of this surgery, and where we should concentrate to be better in the future. So one way is to not operate. But obviously, when you have to do something, at the moment, we do operate, and this PROM rate is between 11 and 50% in the various studies that were compiled by Beck a few years back. The potential candidates for rupture of membranes is the early gestation at laser, the cervical length before laser, the gestational parity for the tolerance of the uterus, the Quintero staging, the death of one twin, the placental location, the operator's experience and the duration of surgery usually put together. We didn't test that because when we looked at this data, we've been running for at least 10 years with a very stable senior staff, so we didn't look at that. Well, if you look at the other factors roughly like this, you see no real individuality in terms of causing rupture of membranes, but there is a kind of a Gordian knot between early gestation and Quintero staging, which I will try to unlock in the next few slides. So again, when we looked at our own series, because it's very nice to compile study and do meta-analysis and systematic review, but if you have the opportunity to have a large continuous series in one centers, then you can probably, providing the team is stable in who operates and how you operate, if it is roughly standardized, then you have a better appraisal of the evolution of the survival longitudinally, rather than taking smaller series from several centers with different experiences and probably different recruitment of patients? Well, that's ours. And what you can see is that from roughly 2010, you can see an increase in double survival, which is in blue. But this increase in double survival is actually paralleled by an increase in rupture of membranes before 32 weeks. But this decrease in fetal loss in green is mirroring the increase in rupture of membranes before 32 weeks. So this was troubling for us, and actually we introduced as a systematic improvement or change to the technique, at least the Solomon technique, in 2013, which was followed by a significant drop in what Solomon technique was going after, which was to decrease the rate of re-intervention and of TAPS after a first surgery by burning continuously the equator, the vascular equator of the placenta. And this has been associated in the secondary analysis of the Solomon trial to a potential increase in rupture of membranes. So before the Solomon technique, what we could see in utero as the brain lesions diagnosed before birth in at least one twin, and we did that study in the pre-Solomon era, was ischemic hemorrhagic lesions in the context of TAPS or recurrence. So we are now in the position of, with Solomon technique, we probably have decreased this source of cerebral lesions in twins, but we may have increased the rate of rupture of membranes before 32 weeks. And what should be done from now on is seriously assess the respective weight of one attitude and the other, which obviously is not going to be easy. I would plead for not doing yet another randomized studies. I think those twins have gone through enough in terms of randomization. I think that we can do studies very seriously, trying to control for biases, and if those parameters are well recorded in terms of technique and co-factors of rupture of membranes or neurological morbidity, a few centers with large numbers could really illustrate and then probably answer the question. Now, preventing iatrogenic rupture of the membranes has been tried using amniopatch, basically at the end of surgery injecting either collagen or platelets in order to plug the entry site through the membranes. The platelets, although they looked promising, they have some unpleasant and potentially life-threatening secondary effect, which is the release of the serotonin from the platelet clot into the amniotic fluid, reaching the fetus with severe bradycardia. For the collagen, I know Michael and Magda, you're using a plug I've seen when I visited you, and you may want to discuss that further in the discussion. On our side, what we've been trying to use, and although those statistics and very small numbers might seem interesting, we were using a small Foley catheter for cases we were doing before 18 weeks of pregnancy in order to compress for a few minutes after the amnioreduction, compress the membranes, trying to seal them. Well, it seems a bit futile because although again these small figures look favorable, the rationale is very weak. Don't see why the membranes would seal properly by just compressing them at the end. So what it seems to reduce is the extravasation, the passage of amniotic fluid through into the abdominal cavity of the mother, but yeah, we're not following that very seriously. Now, mention the effect, the potential effect of the Solomon technique. So if we remove that effect now, so please do not disseminate those slides because they're not published, but papers being written up. If you look at statistics from our centers from the time where Solomon technique was systematically done, so still from 2013 until now, this is roughly 500 cases, so large enough to look at it. You can see that the overall survival at birth is about 80% and 76% is at discharge, and 70% of double survival. So we're still online with what is expected for this disease at the moment. And if we look at the effect of gestational age at surgery in the x-axis, you can see that there is a confusion or a merge of the most severe cases. So the blue and dark blue cases, stage 3 and 4, are much more common in early cases before 19 weeks than later on. And this makes it quite difficult to really extract the role of one and the other, and has probably been a bit mixed up in previous studies. So when you actually adjust for other confounding factors, this is the effect of gestation age on survival. This is a straight line. There is no cutoff where you reach an acceptable survival, whatever that is, because when you operate before whatever 20 weeks, it means that you can't delay the procedure, or you think you can't delay the procedure. So if you look at the probability of double fetal loss, it goes exponentially down with gestational age, and the survival goes linearly up with gestational age, which is when you actually adjust really the effect of gestational age for the location of the placenta, the reference being posterior placenta, supposedly easier technically, the cervical length over 20 millimeter, and if you also adjust for the Quintero stage 3 or 4 effect on survival and complications, then you see that early gestation is definitely a factor of rupturing the membranes before 24 weeks and before 28 weeks, definitely, which really are the two conditions that are the most morbid, despite the positive effect of the surgery on the placenta. And also miscarriages are much more influenced by gestational age than anything else. Because again, this is correcting for cervical length and severity of the disease at presentation. So the lesson from that for the future, well, I don't know, because as our knowledge and the health coverage improves, then you will depict twin-twin transfusion syndrome earlier in gestation before the disaster, which means intrauterine death for one or both twins or spontaneous miscarriage. So centers will be confronted to what we are being confronted to, which is earlier presentations with severe cases that probably would have died about 10 years ago, but that we now are in the position to treat, but to treat with this very high risk of that not to work. So I don't think a trial will help by imposing expectant managements to a group before 17 or 18 weeks, although, as I showed, there is no cutoff of gestational age before which it is more dangerous. So I think we have to live with it and try and struggle against rupture of membranes with whatever clever plugging system could really solve it. Now, the issue of short cervix before surgery. This is in twin-twin transfusion very likely very mechanical by forcing the internal os through the amniotic pressure, as you can see on this fetoscopic image of the internal os. And what we did very early on, this paper in fetal therapy is 15 years old. We, just by observing women miscarriaging with a very short cervix at presentation at laser, we decided to put a cerclage just after the amnioreduction following laser coagulation, and we saw a dramatic change in survival. So we decided to go ahead with this without a randomized trial, which is really futile for this 5% of the TTTS population, really. So I insist on this because I still think, or you may contradict me in the discussion, that in the States you do not operate with short cervix, you do amnioreduction. Where for us, this is an additional criteria for intervention, the short cervix, because we want to solve the problem once for all. So in this group, we put a cerclage. Then we looked at a group of women where we had cervical length pre-laser and post-laser, and therefore we could define three patterns: those for which the cervix will shorten even further after laser, those for which the cervical length will remain stable, and those for which removing the pressure will lengthen the cervical length. And you can see that 30% are indeed increasing the length of their cervix. That mainly remains unchanged, and it is reduced in about 10% of them. When we look at that, cervical length does not appear to be a risk factor independently of others for prom or delivery before 32 weeks. Knowing that when we looked at that, it's not a study of any sort, it's just an observation, we were still putting a cerclage or a pessary, I come back to that, to all those showing a cervix of less than 20 millimeter pre-laser. So if you compensate for this very small group, then does not appear to have an effect to have a short cervix shortening being stable or increasing. And the two factors that remain in this group were single intrauterine fetal death and prom as risk factors for delivery, but that's not a mystery. We've softened our approach by using a pessary rather than cerclage, with the assumption that we were dealing with a mechanical forcing of the cervix, and if anything was to help, was just to sustain, to support the cervix for a while. So we put a pessary, and we've stopped putting a cerclage unless there is no cervix at all, and then it's an emergency cerclage, as traditionally done in those cases in the second trimester. Now, to finish with, if we want to look at the future, or if we want to dream maybe, but then this dream is a bit old already, because the first paper was published in 2016, which is a long time for a promising technique, which is to use the focused ultrasound, the IFU, high intensity focused ultrasound, by which you can coagulate things. So you can burn at least. I don't know if it does coagulate really. This experiment on pregnant ewes was done on the various placental units that you have in a pregnant ewe. And IFU in contact to the uterus could coagulate or could burn, could make vessels disappear in some of those placentals. And whether that is proof of coagulation, I'm not sure, because the histology doesn't help here. It shows clots, but doesn't show damage to the epithelium that is compatible with proper coagulation, as we did with laser 20-something years ago. We don't know if the depth of reach the vessel, coagulating the vessel, could be done through an abdomen, and depending on the placental location, although it's tempting to think that what seems to be an obstacle for laser surgery could be an advantage for HIFU surgery, which is completely anterior placenta. We don't know if the identification of the vascular equator of each end of each patent vessel, the smallest being the most difficult to identify by color Doppler before the procedure, would be feasible. And again, we don't have proof of coagulation. So is it promise for the near future, or is it fantasy that we have been sharing for 30 years with this? Nobody knows, although everybody hopes that ultrasound guided will follow on fetoscopic surgery, as has been the case for many techniques in fetal medicine. But I will leave you with this very deep thought of my favorite American philosopher, stroke coach of the most famous baseball team, Yogi Berra. It's tough to make predictions, especially about the future. And I wish you a very good seminar. Thank you for your attention.
Well, that was a great masterclass, I would say, on laser for twin-to-twin transfusion syndrome. And we'll discuss on some of the topics that Professor Veal has been presenting. Now I have the pleasure to introduce Professor Shamsirzad. He is the Division Director of Fetal Surgery here at Texas Children's Hospital, Baylor College of Medicine. Besides his great expertise in fetal surgery, he also has a significant expertise on placental accreta spectrum disorders, but that is not the topic of today's webinar. Today, Professor Shamsirzad is going to be talking about access in anterior placenta in monochorionic pregnancies and the role for laparoscopic assisted access. And if you are a referring provider or someone who does not do fetal surgery, I think that this is probably a very eye-opening talk, since the access is something that we don't think so much about, but now you can kind of add that perspective whenever you assess a monochorionic pregnancy.
Thank you very much, Magda, for introduction. And again, thank you everybody for joining us for the webinar today. Let me share my screen. Can you see my screen?
Yes.
Okay, excellent. Today my talk will be on it. How can we access on the placenta, on a placenta anterior in the challenging cases for twin-twin transfusion, and mostly I will focus off what is our experience in the Texas Children's Fetal Center and what's going on here. I do not have any kind of, unfortunately, disclosure, and many instruments that I will talk here, these are off-label. However, all of the things that I will discuss there, these are published in peer-reviewed scientific journal. I get back to the principle of the fetal surgery. In reality, you do the intervention if you follow these type of the principle that is established back in 1982. And how we process during the in the world of the fetal surgery, we started with innovation, with simulation. When we report it, we put on the research, and if it's getting critical discussion on a research result, and if it's positive, it will be introduced to clinical practice. With that said, at this point, we do have some recommended fetal intervention and surgery, and we have the level 1 evidence for some of these diseases, such as twin-twin transfusion, that, as Dr. Evil mentioned, went through the RCT and is proven. And then we had a group of the disease and procedures that is level 2 or level 3 evidence, and some of them never can go to the RCT. Back to the twin-twin transfusion, as mentioned before, this is the highlight, the game changer in the field that prove that laser ablation of placenta anastomosis is superior to the amnio reduction regarding the prenatal and neonatal outcome. for the surviving after one fetus and surviving after both fetus is much better with the laser, but also the morbidity to the neonates, such as severe intraventricular hemorrhage and periventricular leukomalacia and intact neurologic outcome is much better in the patient that go through the laser. But as you see, the first outcomes was not pretty high after surviving after both fetus and surviving of at least one fetuses. However, with the improvement of the technique and experience, now we are starting seeing a much more better outcomes compared to the first randomized trial. And as you see, historically, if you look at the outcomes from 995, you start seeing the much better outcomes when you're getting closer to 2020. How we do it, again, I think this is an interesting cartoon that the colleagues in the MFM can realize that how we're doing the laser. This is a twin transfusion. As you see, the recipient become poly and the donor becomes stock and no fluid or oligohydramnios. What we do is through the ultrasound guided, we put the fetoscope in the recipient sac. And after we put in the fetoscope in the recipient sac, we map the placenta and look at the anastomosis. This is mostly done through a sedation and a local anesthesia. And then we're starting buzzing or lasering the anastomosis, and this is called as a selective. That means that we are trying now separating the equator of these two twin. And mostly the intervention will take about 10 to 20 minutes. These are moving target because the mom is breathing, and you need to be very cautious of not touching the placenta with the laser because you can start having some bleed, and that can close and that can obscure your visualization. But after the, finishing and getting all those anastomosis, then we connecting from one side to other, and we connecting all of these dots together. And this is what called as a Solomon technique, as Dr. Evil mentioned before. And this is the technique that the majority of the center at this point accepted. But we do have a challenging for anterior placenta, and the challenging is the scopes that we use is a semi-rigid scope, and we need to have a direct visualization of that anastomosis. With that said, again, with anterior placenta, sometimes you can have a complete anterior placenta, and it's very hard to see those all anastomosis. There are a different approach to this and for the solution of how we can get access and see all of those anastomosis. In some of the cases, if you still have some small window, you can do the tilting of the patient and put the scope. The using of the 30-degree scope is also very helpful. There are some other techniques that they can use it, and I will explain it in the next slide. And also with the new scopes that are available in Europe, and some of the centers in the United States have it. The True Care fetoscope also helping of mapping and doing the laser for the anterior placenta. One of the techniques that was proposed is a trocar-assisted selective laser photocoagulation of communicating vessel. And with that said, again, you come from the side, get inside, and with a 70-degree, you visualize the connections and anastomosis. And then with the trocar, you push the placenta, and from inside of the trocar, you laser those anastomosis. This is one of the techniques that is get us the chance of lasering this anastomosis on anterior placenta. However, if you had a true anterior placenta and there's no window and there's no access, it will be very challenging to get. There is a technique we call it a laparoscopy-assisted laser photocoagulation that is well described in 2007. And we continue to do this technique for the past decade here in TCH. Back in 2015, we put a series of our experience for doing the laparoscopy assisted, and through that experience we figure out the outcomes is pretty similar to the outcome of our standard laser. However, the rate of the P-prom is pretty higher with the laparoscopy assisted, especially close to the 34 weeks. Close to 100% of our patient will have some P-prom if you do the laparoscopy assisted. How we do that technique here, we're starting explaining from, usually we get on a port A inside the maternal abdomen, and that port is usually pretty high because you had a polyhydramnios and you need to avoid getting to the uterus. Therefore, we map the fundus of the uterus, and about 5 centimeters above that, we put our first trocar inside the maternal abdomen. We put the CO2 gas, and then we put our second trocar. It will be mostly on the point D. And with that trocar, we tilted the uterus and we make access through the maternal flank, that will be F, to put the fetoscope to the posterior aspect of the uterus. And then you can visualize the anterior placenta. With that said here, you can see one of our cases. You see the CO2 gas inside the abdomen, and then with another trocar, we tilted the uterus. Therefore, you will have access of the posterior wall of the uterus. And here with an 18-gauge needle, we are coming down to push the posterior aspect. We get inside, and this is the Slanger technique that we use. We put a wire inside, and then we push a 12 French Cook catheter to a posterior aspect of the uterus, and then you can see the anterior wall easily. With that said, recently our fetal surgery fellow, Dr. E.L. Crispin, did another study and looked at a decade of our experience in the Texas Children's Hospital. And this is an IMPRESS in prenatal diagnosis. And through that, we exclude the triplet and all congenital anomaly one. We did have a 31 laparoscopy assisted patient that we compared to our 247 conventional laser. The gestational age of delivery was pretty close, and there was no difference between the preterm delivery, less than 32 weeks, and 28 weeks between the two groups. And also regarding the outcomes at birth and outcomes at 30 days for a surviving of one fetus and surviving of two fetus was pretty similar between the two groups, and there was no significant difference. However, when you look at the sub-analysis, the interesting part was the ones that had a laparoscopy assisted, we did a more complete Solomon for those patients when compared to only the anterior placenta one as a standard, and those are 83 patients. However, again, look at the other outcomes regarding the live donor and a live recipient at birth, and at 30 days, there was no difference between the two groups. In a conclusion, we mentioned that in a situation where the twin-twin transfusion require laser and where a complete anterior placenta severely restrict access, laparoscopy assisted may be a consideration. And when performed by an experienced team in a fetal center with specific expertise, this surgical approach has been shown to increase the completion rate of Solomonization and successful laser. Thank you very much for your time, and I will encourage everybody to put a question in a QA or a chat box that we can discuss the first two presentations. Thank you.
Thank you so much, Shami, for a very important aspect about the surgery in twin-to-twin transfusion syndrome, which is the anterior placenta. I'm aware that Dr. Veal is having some connectivity issues, so we're just going to start some of the discussion based on the comments that are in the chat box. Professor Miller, please feel free to join us, and Professor Stinnerman, please feel free to join us about the answers for these questions. They've been asking what factors would make you opt in or out for Salomonization? So we can start with you, Shemi, and then Gina, you can also let us know, what do you think?
I think it's a very interesting question. Again, recently we were working on a meta-analysis that still is not published, therefore I can't get through the details. But the Solomon technique, as shows on RCT, it will significantly decrease the chance of the TAPS, iatrogenic TAPS, and also recurrence twin transfusion. And we know that these are the two, very big issue if you have it, and they will increase significantly the risk of neonatal mortality and morbidity when you end up with a TAPS or recurrence twin. Therefore, I think for some of the cases, the solemnization is should, especially if you don't have a good visualization. However, if you had a very good visualization, now is a question that do you really need to buzz and make that Solomon, or do you really need to give much more energy to the placenta, especially if some of your equator is on a donor side, and that is can cause an increased risk of the PPROM, as Dr. Evil mentioned in his talk in his series and publication back in BJAG in 2018. Therefore, talking with different people around the country, I think some of them back it up from doing the Solomon for all the cases, but I think it needs to be individualized and go case by case.
Thank you. Gina, what do you do in Johns Hopkins in your fetal center?
We primarily use the Solomon technique as an intended procedure for all of our lasers. However, there are a few circumstances where it may be safer if there's no visualized vessels to avoid that. For instance, if it requires direct contact with the placenta based on the access and the angle to the placenta. So those are the few circumstances where we may partially not complete the Solomon technique all the way across the placenta. Or at times, if you are lasering through the sheath and with a complete anterior placenta, in order to avoid contact or through the sheath up to the entry point. So those are the few cases where there may be a portion of the placenta that is unable to be accessed or completed.
And Gina, in your experience, do you do laparoscopic assisted lasers for cases of anterior placenta?
In my last institution, I had done one case like that for a complete anterior placenta. However, currently we haven't utilized that technique at Johns Hopkins. We simply rotate the patient as much as possible to get as lateral of an entry in a safe place to avoid the broad ligament and any myometrial vessels. Now, whether the challenge is, those are our cases actually where we have had recurrence and TAPS almost exclusively in our series.
Mm-hmm. Thank you so much for that answer, and welcome, Julian. We have a question that was addressed originally to Professor Bill. We're seeing that he still has some issues with connectivity. So I would like to address that question to you, as it is about the practice of Necker Hospital, where you both work. So they said in one of the questions by Cecilia Villalain, there is no gestational age from which all of those risks increase, which is reasonable considering that gestational age is a continuum. However, would you argue for waiting to perform surgery and gain days or weeks, and apparently results would not worsen if TTTS progresses, or would this benefit be minimal? So I think that this is a very common situation that we have in our practice. 16-weeker stage 1, 16-weeker stage 2. Do we wait? Do we not? How would you manage that, Julian?
So yeah, can you hear me? Yeah, I'm the attic of my country home. Don't mind the noise. I don't know if the Wi-Fi connection is that good here, but yeah. So yeah, early gestational age, and 16 and before that, actually, sometimes we get patients with acute TTTS from 14 weeks on. So my talk is for just after or sometime after, and it's about stage 1. So stage 1, my opinion about stage 1 is that, all right, we have a randomized trial. I'll give you the results. It might not have been completed in terms of power, but what it shows is that really there's not much benefit in operating early on these. I mean, in my opinion, at least, there's not much benefit in operating immediately those stage 1. And it's probably preferable to follow them up a bit to see if they progress or not. And some of these, I mean, like 40% will not progress. And in those cases, I think because 40% don't progress, it's probably worthwhile waiting, especially in those very early cases. So let's put the stage 1s aside, and let's look at the stage 2 and beyond. My opinion might differ from Yves' opinion. Stage 2 is very much like stage 1. All right, stage 2 is pretty much the same kind, just the bladder is smaller, not cycling anymore. So if it's really early, like 14 weeks, 15 weeks, I would wait. Unless the cervix is short or there is any kind of emergency going on, obstetric emergency, I would wait at least for a couple of weeks, and it's likely that you will be able to operate at 17 weeks, and she will not have miscarried before that, or the syndrome progressed to a stage 3 or 4. Now, the difficult question is when you're facing an early stage 3, because those early stage 3, I think we have a paper, or we published a paper about that. I don't know if we put that kind of result in. I can't really remember. It's only last year. My memory is pretty bad. But those very early stage 3, they are also associated with very commonly associated with severe IUGR. And in that kind of situation, the question is not, will the syndrome progress, or will that poly get so intense that she will miscarry? The question is the very small IUGR donor twin, is he going to die before you operate or not? And so that kind of a balance is very tricky. And my feeling is that if the growth discordance is less than 30% and you still have a positive A wave, you could wait a bit. But from 16 weeks on, then I guess in those cases, stage 3, I'd operate. But before 16 weeks, if you still have a positive A wave on the ductus venosus and you have a discordance in AC or estimated field weight less than 30%, I mean, especially if it's an anterior placenta, difficult procedure, I mean, I could wait a bit.
We apply a very similar algorithm, Julian, so it's good to hear that it's also extensive to other centers, even in different countries. Thank you so much for your answer about that. So in order to try to stay on time as much as possible, we're going to go ahead with the next presentation. I see that there's a question about TAPS after surgery, and that question will be answered in one of the following presentations. So our next speaker is going to be Professor Stinnerman. He is a fetal surgeon, and he's a fetal medicine specialist who practices at Necker hospitals in Paris. He is the first author of the study that we're going to be hearing. There's not so many randomized controlled trials in our field because they're extremely difficult to perform, and he's one of the ones that performed one in a multi-center fashion. So kudos to him for doing that. We're going to be talking and listening to the results of this stage 1 in twin-to-twin transfusion syndrome, and hopefully we'll have a decision about whether it's beneficial to treat or not to treat. We can display his video, Tiara.
Hi. Now, thank you all for the kind invitation to give this lecture. And unfortunately, we still have to resort to Zoom and pre-recorded lectures, but I hope we can have an interactive session with questions later on. Now, this talk is focused on the results of a recent international trial evaluating the optimal treatment for stage 1 TTTS. But before we get into the design and the results of the trial, I'd like to give an overview on the developments of fetoscopic surgery for TTTS and why this trial was necessary. Now, the advent of fetoscopy for the treatment of TTTS was first carried out in 2004 by an international trial comparing serial amioreduction, which was the standard of care at that time, to percutaneous fetoscopic laser of a placental anastomosis. This first randomized trial was stopped early for efficacy after enrolling only 142 women, 72 in the laser arm and 70 in the amnioreduction arm. The results of the trial showed significant improvement in both perinatal and neonatal outcomes. Laser significantly improved survival, both in early stages of the disease, Quintero stages 1 and 2, as well as in advanced stages 3 and 4. A fetoscopic laser also resulted in less preterm births, with a mean gestational age of 33 weeks compared to 29 weeks following amnioreduction. Not only did laser improve survival and preterm birth rates, but it also significantly reduced postnatal neurological morbidity of the condition by significantly reducing the rates of severe intraventricular hemorrhage and periventricular leukomalacia, thus increasing the rate of survival without neurological morbidity from 31% following amnioreduction to 52% following laser. Following these results, percutaneous fetoscopic laser coagulation became the best first-line treatment for TTTS, although the condition still resulted in only 1 of 2 fetuses being alive and well after treatment. Since these early days of fetoscopic surgery, the equipment has not really changed much, but several technical refinements were introduced following the trial in the 2000s. One main refinement was to target the vascular equator, a theoretical line that divides the placental vasculature of both twins on the chorionic surface, represented here on the figure by a dotted line, instead of coagulating all the vessels at the membrane insertion represented by the solid green line. A non-selective procedure, using the intertwin membrane as a landmark during fetoscopy, is more likely to result in an unfair division of the placental mass, usually at the expense of the donor twin. Whereas in a selective procedure, the anastomoses are specifically coagulated along the vascular equator, resulting in the fairest division possible, thus increasing the chances of survival of both twins, particularly increasing the chances for the donor twin to survive. However, despite the efforts to selectively coagulate all intertwin anastomoses, postpartum ex vivo injection of placental vessels found patent anastomosis in up to 1/3 of all procedures, explaining the observed rates of postoperative complications such as recurring TTTS, dual fetal demise, and twin anemia polycythemia syndrome, or TAPS. Now, TAPS is a particularly severe condition in which one twin, usually the ex-recipient, is found anemic, and the co-twin, typically the ex-donor, is found polycythemic. By direct fetal-fetal transfusion through a single and often small anastomosis. Although a repeat procedure may identify the remaining anastomosis and treat the complication, TAPS and recurrence are responsible for a significant proportion of postoperative morbidity. The poor outcome following postoperative TAPS was recently described in a multicentric collaborative study of 164 cases. This study showed that the condition was associated with an exceedingly high mortality, both prenatally and postnatally, as well as with an 11% rate of neurological injury. Now, several hypotheses could explain the high prevalence of incomplete surgery, but the most likely one is that some vessels were just too small to be visible by fetoscopy and are therefore overlooked during surgery. Therefore, it makes sense that coagulating the whole equator, as on picture B, instead of targeting the anastomotic vessels as on picture A, would help reduce the number of uncoagulated vessels and thus reduce the rate of associated complications. This hypothesis was demonstrated in a second international trial, specifically comparing the standard selective technique to the so-called Solomon technique, which I believe was named after the wise King Solomon and the famous story of his judgment. The results of this trial confirmed the hypothesis with a significant reduction in the rate of postoperative TAPS from 60% to 1%, as well as in the rate of recurrence of TTTS from 7% to 1%. However, there was no effect on overall survival or neonatal brain injury. Another complication of fetoscopic surgery is PPROM. In this figure, the red line represents the change in the rate of post-op PPROM occurring before 32 weeks over a 16-year period in our center in Paris. Whereas it was below 20% in the early 2000s, it has rapidly risen to reach almost 40% in 2016, along with an increase in the rate of preterm birth before 32 weeks, reaching 55%, the green line. Concurrently, however, the rate of dual survival has also significantly increased over the same time period, from 40% to 65%, the blue line, together with a decrease in dual loss depicted by the black line. So we could argue that it is possible that since improved post-operative survival results in an increase in the number of ongoing pregnancies, the rate of obstetric complications, such as PPROM, mathematically increases. However, in a post-hoc analysis of the Solomon trial, Ackermans suggests that the 42% rate of PPROM observed in the trial in the Solomon arm may be related to a higher amount of energy delivered while coagulating the whole equator, resulting in more severe membrane damage. It is therefore possible that the Solomon technique itself is at least partly responsible for the high rate of PPROM we observe. Now, given the potential morbidity associated with fetoscopic laser, there has been a long-standing debate on whether or not to operate cases presenting with stage 1 disease, defined only by polyhydramnios in one twin and oligohydramnios in the co-twin, while the bladder is still visible and without Doppler anomalies. Indeed, the data from the previous trials was insufficient to specifically address the question of stage 1, and opinions were divided regarding the optimal treatment in those cases. Several observational cohorts suggested that stage 1 could be successfully managed without surgery in up to 60% of the cases. An international survey published in 2010, just before we started the trial, showed that despite the undisputed benefit of laser in TTTS, expectant management was the preferred strategy for stage 1 disease amongst North American and European centers. Later, in 2016, a NAFNet collaborative retrospective study of 124 cases suggested, however, that primary laser is associated with better outcomes than expectant management. We therefore had an equipoise for a trial given that the risks of intrauterine surgery, including premature rupture of membranes in up to 40% of cases, miscarriage or preterm birth, intrauterine fetal death, twin anemia, polycythemia sequence, and chorioamnionitis may be worse than that of the natural history of the disease itself in the case of stage 1 disease. The inclusion criteria for this trial were asymptomatic stage 1 TTTS with a long cervix. That is, only patients with a TTTS defined by oligohydramnios in one twin and poly in the co-twin, without Doppler anomalies, without polyhydramnios-related maternal symptoms, and with a cervix longer than 15 millimeters. Patients willing to participate were randomized by a central internet-based program, either to immediate laser or to expectant weekly ultrasound follow-up. In these patients managed expectantly, rescue surgery was readily available in case of progression in Quintero stages, maternal symptoms such as dyspnea or contractions, or rapid cervical shortening. The primary outcome was defined at the neonates level by a composite outcome combining death or neurological anomalies at 6 months postnatally. 100 patients in each arm were required. In the end, nine centers participated in France, the United States, Netherlands, Germany, and Belgium. The trial started in 2011 and ended in late 2018 with 117 of the 200 initially planned inclusions, when the DMC, the Data Monitoring Committee, chose to end the trial because of slow inclusion rate. During the inclusion period, no severe adverse event was declared, and the analysis we present is based on the 6 months postnatal outcome. Overall, during the inclusion period, 164 pregnancies with asymptomatic stage 1 TTTS were eligible. 47 refused the trial, and 117 were randomized between immediate laser and expectant management with weekly ultrasound follow-up. Within the 58 cases allocated to expectant management, about 40% remained stable throughout the course of pregnancy and were delivered without surgery, where rescue surgery was performed in 60% of these patients because of progression in stage, maternal symptoms, or cervical shortening. At 6 months postnatally, 89 and 92 infants were assessed for primary outcome in each arm, with less than 5% of loss to follow-up. The results of the trial show that there were no difference in primary outcome between expectant management and immediate surgery. The rate of death or neurological anomaly was 23 and 22% in each arm. The components of primary outcome were also similar between both arms, with a rate of neurological impairment at 6 months of 4.5% and 2.6% in expectant management and immediate surgery, respectively. The mean gestational age at delivery was between 32 and 33 weeks in both groups. However, PPROM occurred before 32 weeks in 31% of cases following immediate surgery, significantly more than in women allocated to expectant management. The overall survival rate per pregnancy in terms of 0, 1, or 2 twins alive at birth was similar in both arms. Following the initial allocation to expectant management, rescue surgery was required in 60% of cases during follow-up in this group, mainly for progression to Quintero stage 3 or 4, which accounted for 60% of the indications for rescue surgery. Breaking down our results between cases that required rescue surgery and those that did not, the rate of death or neurological anomaly at 6 months was lowest in those cases that did not progress, although not significantly. Following rescue surgery, the rate of neurological impairment was 7.7% and 0 in non-progressive case. We also found that the rate of 96% of dual survival in cases that did not require surgery was significantly higher than the 74% rate of dual survival following rescue surgery. Furthermore, mean gestational age was higher in this subgroup, although not significantly. Therefore, it appears that women with stage 1 that do not worsen during follow-up display the best outcome, with a higher survival rate and possibly less prematurity and neurological impairment. We therefore sought to determine possible risk factors for disease progression, either by maternal symptoms or Quintero stages. For this analysis, we took advantage of the cohort of women that declined to participate and performed analyses on the total population of patients initially managed expectantly, thus adding 26 cases to the 58 cases randomized to expectant management. Potential covariates were gestational age at randomization, a cervical length less than 30 millimeters, a deepest vertical pool of more than 10 centimeters suggesting intense polyhydramnios, increased discordance in abdominal circumference, and nulliparity. We also analyzed anterior placenta and obesity as potential markers for decision bias for surgery. Although it appears that neither anterior placenta nor BMI influenced surgeons to operate or not during follow-up, none of the potential covariates were associated with disease progression. In conclusion, this trial has shown that expectant weekly follow-up is a reasonable option for asymptomatic stage 1 TTTS with a long cervix. We also have shown that 60% of patients managed expectantly will progress and that surgery will be required on average 2 weeks following diagnosis. However, the outcomes following rescue surgery are similar to those following immediate surgery. The 40% that do not progress during follow-up display the best outcome, with a rate of dual survival above 90% and less than 5% of neurological impairment at 6 months. Thank you very much.
Okay, thank you very much. Julian, was a great talk. Probably we'll have lots of questions after our next speaker. I'm happy to introduce our next speaker is Dr. Magdalena Sanz-Cortez. We are lucky that she joined our team in 2015 from Barcelona. She's the expert in fetal intervention and also her other expertise in fetal neurosurgery. She did have wonderful work with the fetoscopy neurotube defect repair, and she's leading lots of research in that field and also leading the initiatives such as International Consortium for Fetoscopy Myelomeningocele Repair. We are happy to have you here, Magda, and all is yours.
Thank you, Shami. I'm sharing my screen. Can you see my screen?
Yes, we can see your screen.
Wonderful. So the talk that I'm going to be giving today is how to care for your patient after laser. This is a very practical talk. So after you do a laser or someone else does a laser for twin-to-twin transfusion syndrome in a monochorionic pregnancy, and the patient comes back to you or you continue with the care of that patient, you need to be aware of what are the most common complications that can be occurring after that kind of surgery. So by ultrasound, we can attest after laser that there could be a fetal demise. And that is likely related with more severe cases of twin-to-twin transfusion syndrome, and especially those that have an associated diagnosis of selective fetal growth restriction. However, there's some other complications that it kind of proves or tests your ultrasound skills, and those are the ones that I want to be talking about today for the most part. So there could be complications such as transient donor hydrops, chorioamniotic membrane separation, septostomies, and also the detection of pseudoamniotic band syndrome. We could also observe complications that are more relevant for the life of those fetuses, such as the diagnosis of postoperative TAPS, reverse twin-to-twin transfusion syndrome, and also persistent twin-to-twin transfusion syndrome. In the follow-up of these babies, you could also detect by either ultrasound or MR signs of neurological compromise or brain injury. And of course, in the follow-up of these pregnancies, the big Achilles heel, as we have been hearing in previous talks, is the outcome of having a preterm delivery and also having preterm rupture of membranes. So let's start with one of the more or less commonly known complications, such as the detection of transient donor hydrops. This diagnosis is caused by a transient congestive heart failure that is associated with a sudden interruption in the intertwin transfusion. 17% of twin-to-twin transfusion syndrome cases might present with transient donor hydrops after a laser is performed. And the average for the timing of its presentation is about 2 days after laser, and typically it lasts somewhere between 5 to 7 days after surgery. The post-laser donor hydrops can be considered as a sign of poor prognosis, as it can appear prior to the demise of these fetuses. This has been recorded in almost 6% of the cases in the first 2 weeks after laser. The predisposing risk factors for developing transient donor hydrops that has been identified in literature is observing a low intertwin weight discordance, and especially in the more severe stages of twin-to-twin transfusion syndrome. The detection of another complication that is very relevant, and we have done a lot of studies about it, of chorioamniotic membrane separation is worth a little bit of time for explanation. Chorioamniotic membrane separation seen after laser can be a risk factor or a red flag for the detection later on of PPROM, preterm delivery, IUFD, and the development of potentially amniotic band syndrome. When we have this finding that you can see on the screen as that membrane that is floating, separating itself from the uterine wall and floating freely in the amniotic cavity, that's when you have to make your diagnosis of chorioamniotic membrane separation. And it can be seen up to 20% of the cases after laser surgery for twin-to-twin transfusion syndrome. It's more common even in other conditions, such as, for example, open spina bifida repair and fetoscopic spina bifida repair that can be seen in 50 or 40% of the cases, respectively. So definitely it's a complication that if you are familiar with managing monochorionic pregnancies after laser, you will be seeing. And the most common timing of its presentation is 1 week post-operatively. In fact, 95% of the cases show chorioamniotic membrane separation during the first 3 days after surgery. So the factors that predispose a case for developing chorioamniotic membrane separation mostly is the gestational age at surgery. Those cases that occur early, like less than 20 weeks or less than 18 weeks, the chances for developing chorioamniotic membrane separation are increased by 3 times. And once the chorioamniotic membrane separation is detected, this increases the risk for miscarriage, for PPROM before 32 weeks, for preterm delivery less than 32 weeks by 2 times, and overall it's just associated with a lower gestational age at delivery and poorer perinatal outcomes. So when we see this finding that you are seeing in the video, a complete chorioamniotic membrane separation, so more than 50% of the membranes in the uterine cavity are presenting as detached, that is a finding that is even more concerning than milder forms of chorioamniotic membrane separation. So there's a gradient about the severity of chorioamniotic membrane separation with adverse perinatal outcomes. It increases significantly the rate of miscarriage. It is presented more commonly in those cases with lower gestational age at surgery, and definitely there's a very clear association between complete chorioamniotic membrane separation and PPROM at less than 28 weeks. So this is a finding that if we see after laser in our patients, I would recommend to translate that information to the patient so that even if it's a small leakage of fluid, patients actually report about it and go to the emergency room so that it can be treated as PPROM in case there's leakage of fluid. The other complication that can be appearing after laser for coagulation of the communicating vessels is an inadvertent septostomy. So that means, as it's shown in this diagram, that after twin-to-twin transfusion syndrome, surgery is performed, as you can see here with the trocar and the fetoscope going through. There can be perforation of the membranes that will not seal or would not be as closed or as small as it should be. In some cases that develop inadvertent septostomy, that perforation of the membrane would extend, and therefore we would be seeing that the reestablishment of amniotic fluid in the oligohydramnios baby is pretty much immediate, or it happens later on. The degree of the reaccumulation of fluid in the donor depends on the how much we're treating the condition of twin-to-twin transfusion syndrome, and also in case this complication appears based on the size of the septostomy. So this is a case that we had in our experience that we did the laser at 22 weeks. The patient was admitted at 27 weeks because we found that there was a very large septostomy. So we thought that it was reasonable to manage this patient as we would for a mono-mono. This patient ended up delivering at 33 weeks by a C-section due to preterm delivery. And you can see the finding in the umbilical cords of both babies, very similar to what we'd be seeing in a case of mono-mono. So these cases of very large septostomies, they should be managed in the same way as mono-mono pregnancies, because this is in reality a iatrogenical situation of that high-risk complication. It is established that 7% of the cases after laser develop septostomy during the first week after the surgery, and it is typically diagnosed as that typically free-floating intertwin membrane that is flapping, and then the reaccumulation of fluid in the donor sac that is at a much higher speed than what would be anticipated in case septostomy was not detected. Even if the defect is initially small and well-defined, the septostomy often leads to a complete tearing of the intertwin membrane, presenting with free-floating flaps, and these could lead also to fibrous strings, and that could be a complication itself. And the risk factors to develop septostomy, it has been directed into those cases that we need to actually coagulate those vessels on top of the membrane. So it has been suggested that as much as we can to avoid that coagulation of the vessels on top of the membrane to avoid this complication. So once we have this septostomy and those fibrous strings are developed, that can lead to this complication that is called pseudo-amniotic band syndrome that can be seen in up to 3% of the cases post-laser. The risk mainly of developing pseudo-amniotic band syndrome is increased by the occurrence of septostomy in these cases, which accounted for 50% of the cases with complicated with pseudo-amniotic band syndrome. In some cases that those bands are jeopardizing or threatening the integrity of a limb or the umbilical cord even, there could be a consideration of doing a second intervention for laser in order to release those bands that could be constrictive. So whenever we have iatrogenical monochorionic monoamniotic pregnancies, these can lead to worse perinatal outcomes, and this is not just related to PPROM at less than 32 weeks, but also it is very much related with preterm delivery at less than 32 weeks. It increases the chances by 7.5 times, and it also increases the chances of having fetal demise, likely because of the development of this pseudo-amniotic band syndrome. The other complication that we can observe after laser coagulation in twin-to-twin transfusion syndrome is the development of twin anemia polycythemia sequence. And we have heard and seen these images in previous talks, but I think that that is reflective of how relevant it is to detect this type of complication. Up to 33% of the placentas treated with laser might still have residual anastomosis, and these are typically very, very small. The Salomon trial showed that complete decoronization using the Salomon technique would reduce the recurring twin-to-twin transfusion syndrome, and more importantly about this complication, it would also decrease the incidence of TAPS, going from 16% to 3%. There is also a significant reduction of residual anastomosis using the Salomonization technique, which can be helpful in the reduction of TAPS. So we know that whenever we have a monochorionic pregnancy, the incidence of spontaneous TAPS is up to 5% of the cases. And when we are looking into post-laser cases, it can be detected up to 16% of the cases. These can be diagnosed, and the more classical or most commonly used defining criteria is if the peak systolic velocity of one twin is at 1.5 MOMs or higher, and if the other one simultaneously is at less or equal to 1 MOM. Whenever we have twin anemia polycythemia sequence, we have to also inform the patient that the risk for neurodevelopmental delay is as high as 20%. Now, there has been a recent report in 2019 by one of the teams internationally that are more focused on TAPS and its definition, proposing a new defining criteria for the detection of TAPS, which is the assessment of the delta or the difference in the MCA peak systolic velocities. If it's more than 0.5 MOMs, they have suggested that these could have a greater diagnostic accuracy for predicting TAPS compared to current criteria. However, that was just based on one report. Other teams are also researching and investigating on this delta value of the peak systolic velocity between both babies, but currently we're still sticking to the classic definition of it that you can see on the screen. Currently, we are using this definition, but also this staging criteria that is very similar to the Quintero staging criteria for twin to twin transfusion syndrome, but applied to TAPS. So we would say that there's a stage 1 TAPS if there's more than 1.5 or less than 1 MOMs of the peak systolic velocities in both babies simultaneously. We would say that there's a stage 2 if this difference in peak systolic velocities is even more pronounced. So if it's equal or more than 1.7 MOMs in one baby, and simultaneously equal or less than 0.8 MOMs in the other baby. Stage 3 is when, besides having this difference in MCA peak systolic velocities, we would be seeing that there are Doppler abnormalities similar to what is a stage 3 twin to twin transfusion syndrome, so abnormal umbilical artery Doppler. And then if we would be seeing hydrops, it would be stage 4 and stage 5 if there's already a fetal demise. So very similar to Quintero staging, and we use that for our clinical management and in order to make clinical decisions in these cases. Currently, there's not enough evidence to determine what's the optimal management for TAPS in these monochorionic pregnancies. Different authors have been reported the performance of fetoscopic laser surgery, intrauterine blood transfusions, the combination of partial exchange transfusion in the recipient, or even the opportunity to offer selective feticide or just doing nothing at all. Keeping in mind that TAPS, when it's detected, sometimes it is after one laser has already been performed, and how in some cases of TAPS, we're not going to be seeing the polyhydramnios, oligohydramnios situation that we have in TTTS. It is easy to understand that performing laser in TAPS cases is not always going to be as straightforward as in twin to twin transfusion syndrome. So there can be a component of a technical challenge in these cases that should be accounted for when we are deciding what's the best intervention for cases of TAPS. So this is the proposal from the same team that, as I said before, it's very focused on TAPS. It's a team from the Netherlands, and they have proposed that if we see a TAPS stage 1 and 2, we should be performing close monitoring. If it's quickly progressing into stage 2, or if it's a stage 3 or above, they would suggest to perform an intervention that if it's less than 28 weeks, we could be giving a chance for laser. And if it's less than 32 weeks and laser is not feasible, then we should consider performing intrauterine blood transfusion. And if it's more than 32 weeks, definitely we should consider the option of delivery in these cases. Different authors have emphasized the need for a randomized controlled trial for TAPS. I'm not sure if this is going to be the case, as efforts in a multi-center international studies like this are definitely very challenging in our field. So I just want to show you what are some of the proposed management algorithms for monochorionic pregnancies after laser. I would like to highlight the guidelines from ISUO for monochorionic pregnancies. Basically, the follow-up is typically after 16 weeks, every 2 weeks. And there are some points that I just would like to remark about this guideline. At 20 weeks, they suggest to do cervical length. However, in the guidelines, it says that screening for transvaginal ultrasound for short cervix in TTTS cases has also been proposed, as this is associated with preterm birth. A known complication of TTTS, as there are no interventions shown to improve outcome based on short transvaginal ultrasound cervical length in TTTS cases, this screening cannot be recommended at this time. So this is one of the areas of controversy in the management of monochorionic twins. We do not perform this intervention. In cases of demise of one twin after laser, brain imaging of the surviving co-twins should be considered at 4 to 6 weeks after laser, and neurodevelopmental assessments should take place at 2 years of age. We recommend that if there's the opportunity of doing neurosonology, that would be ideal. However, it also says that some centers offer fetal brain MRI at 30 weeks to all survivors after laser in order to detect brain abnormalities such as migration and proliferation disorders. However, evidence to support this practice is limited, and the specificity of diagnosis and how to translate into long-term neurological morbidity is unknown. So some centers do so, but if your skills in neurosonology are very advanced, I would recommend to use neurosonology first. So these guidelines suggest that at each one of the ultrasound scans that is performed every 2 weeks, fetal biometrics should be performed, assessment of amniotic fluid volume with deepest vertical pocket. Also, Doppler of umbilical artery and ductus venosus in both twins should be performed. We should assess the discordance of estimated fetal weight, and a peak systolic velocity of the MCA should be recorded after 20 weeks of gestation. And the other complication that we can be observing in these post-laser monochorionic twins, as it has been explained in previous talks, is PPROM. PPROM is definitely the Achilles heel of laser cases. It has been recorded in up to 40% of the cases that undergo this type of intervention. And in 28% of these cases, it has been seen at less than 24 weeks. 50% of them delivering within 24 hours after PPROM, and this is a big trigger for neonatal demise, extreme preterm birth. The mean gestational age at PPROM seen in this series is 27 weeks, and definitely PPROM is a big driver to decrease gestational age at delivery. If it's detected, it decreases gestational age at delivery by almost 4 weeks of gestation. There are no differences in the incidence of PPROM regarding the cannula size, the performance of amnioinfusion or amnioreduction. And it has been seen in different authors that potentially the placement of collagen pads could increase the risk of PPROM. So regarding the time of delivery, and just finalizing this talk, there is limited evidence on the time and route of delivery for monochorionic pregnancies previously treated for TTTS. In general, we would say that 34 weeks after a course of steroids would be indicated, and we would recommend to administer 1 round of steroids if more than 24 weeks, up to 34 weeks in severe forms, or if there has been laser. It is also reasonable to adopt a similar strategy as for what has been proposed for all monochorionic twins, to deliver at 34 weeks if persisting anomalies and up to 37 weeks if there's a complete resolution. Delay in delivery until 34 to 36 weeks might be reasonable even after successful laser ablation, and this is the recommendation as well by SMFM. I thank you very much for your attention, and I'm open to any question.
Thank you very much, Magda. It was a great talk. I think for the sake of the time, maybe you can introduce the next speaker, Dr. Miller, and then at the end, we'll do the question and answer.
Wonderful. So it is my pleasure to introduce Professor Gina Miller. She is a fetal surgeon at Johns Hopkins Hospital Fetal Center, and she is an extremely experienced fetal surgeon, not just in the monochorionic surgery arena, but also in other interventions such as spina bifida and other interventions that are performed in fetal surgery. It is my pleasure to introduce her for her talk, 10 in 10. So she's going to stress out or emphasize on what are the top 10 most important things to keep in mind for an optimal management of complicated monochorionic pregnancies. Gina, the floor is yours.
Thank you so much for the invitation to share our thoughts and experience on this topic. And this is something that's quite dear to me. So I will share my screen. Is that working?
Yeah, we can see it very well.
Okay, very good. Okay, so 10 and 10 things you should not miss out in the management of monochorionic twins. So first of all, I have no disclosures to report. And for convention, throughout this talk, for some of the examples, fetus A is always referred to as the recipient or the larger fetus. Fetus B is the donor, the growth-restricted fetus, or the one that may have anomalies. And in our center, our colloquial thing that we say with our parents is really never trust monochorionic twins until they're delivered. And so you must always have a very high index of suspicion that they can misbehave on you through the entire time of the pregnancy. So first of all, remember that chorionicity is a continuum. We have the paradigm established of when the split of that embryo occurs and when that develops into our di-di twins, mono-di twins, mono-mono, and conjoined twins. But recognizing when you monitor a lot of monochorionic twins, things do not always follow the rules. And so when you see signs of monochorionicity or you see things that might suggest there could be a complication of monochorionicity, you should believe it, because partial monochorionicity does exist, and we have certainly seen this within our practice and on pathology specimens. So if a pregnancy appears that it may have features of monochorionicity, believe it. Also, determine that as early as possible. It does not get easier with time. Very early in the first trimester, you have the classic ultrasound findings of the monochorionic twin on the right and the chorionic diamniotic twin on the second image. And it's important to see on that lambda sign that you have placental tissue inserting in between that thick membrane. Because if that area is clear and that's a false lambda sign, you can be fooled by that. Additionally, very early in the first trimester, it's important to always utilize your transvaginal scan, particularly in that early time where pregnancies can be confused as being monoamniotic rather than monochorionic diamniotic pregnancies. And so that can certainly impact our early counseling. Additionally, determining that chorionicity does not get easier with time. In the first trimester, you must figure it out because most of the signs that we use on ultrasound are gone up to about 7 to 10% of the time through the second trimester. So we can figure this out nearly 100% with 100% sensitivity and specificity in the first trimester. So please work very hard in the first trimester to assign this for your patient. Third of all, the risk assessment for monochorionic twins begins in the first trimester. They are certainly not all the same. And very early at that time of the 12-week scan, you can figure out which of these are going to be your most predicted to be a high-risk course and those that are more reassuring and are more likely to have a low-risk course. But those low-risk pregnancies, it's very important to remember that they are not out of the woods for adversity, and about 20% of them may experience complications of monochorionic twins. So in that first trimester, when there is a difference, most importantly in fluid and in size, it is time to begin the counseling on the surveillance strategy. Additionally, those pregnancies that are identified high risk, they should not go down your standard every 2-week assessment for surveillance. So begin and shorten that surveillance interval early. Number 4, also in the first trimester, when things look very unusual, consider that something very unusual may be going on. So for instance, you might have one completely normal appearing twin, normal NT, normal CRL, normal Dopplers, normal anatomy. And in this example, the second fetus has multiple severe anomalies. So a flattened face, a cleft, a lobar holoprosencephaly, and a reverse ductus venosus A wave. And so the consideration as well, is this simply just a case of discordant anomalies, or could there be more going on? And so standard in the first trimester, you may do your CVS and find a normal result, but that may not represent the case for both twins. And so in these particular cases with severe difference in discordant anomalies, remember that their karyotype may actually be different. And so that may also affect your management planning moving forward later into the second trimester. And so Post-zygotic mitotic errors certainly can happen after the blastocyst stage and may be responsible for about 5% of karyotype abnormalities in monochorionic twins. And so this was a case we published recently in Ultrasound and Obstetrics and Gynecology. Next, moving into the second trimester, the monochorionic placenta does not discriminate at all. When you are evaluating a pregnancy of monochorionic multiples, you must evaluate for the entire spectrum of the conditions. So this placenta, I think, is an excellent example from one of our pathology specimens. So you see the features that contribute to all of the standard complications that we're evaluating for. So you have very large and small AV anastomoses. You have an example of a large artery-to-artery anastomosis within this rectangular space. You have a difference of placental share, as well as discordant cord insertions. So the features of this placenta can represent all of the things that we see for both twin-twin transfusion syndrome, selective fetal growth restriction, and TOPS. So there can be not only, these can coexist at the same time, and you might have features of all of them within the same pregnancy. So every time, evaluate for the entire spectrum of disease. Especially twin-twin transfusion syndrome by far is the biggest target of our surveillance strategy, but you must avoid the pitfalls of amniotic fluid measurement. So when it's kind of rare that we see this type of presentation now, where we see massive polyhydramnios in one twin and very advanced TTTS. However, don't forget and don't miss the stuck twin here at the top. If you are struggling to see the membrane and there is a lot of fluid, this is twin-twin transfusion syndrome until proven otherwise. Additionally, when you have massive polyhydramnios, beware of the ultrasound artifact in this picture here on the right, because you get that change in the echogenicity from that reflection from the bone. And this was an example brought to me where the sonographer measured 6 and 6 of amniotic fluid, when in fact, this is the membrane. So always be sure that you're seeing exactly and appreciating the difference in amniotic fluid. Next, although this is a little bit less common of a presentation, what's a little bit more common is identification of oligohydramnios in a single fetus. And so in this case, where we have normal amniotic fluid and oligohydramnios, this may precede actually the development of clinical TTTS. But what is important to recognize is the membrane folding that you can see when the fetus stretches out the extremities. You may see that become evident. And especially in an anterior placenta where you have the fetus suspended and the membrane wrapped around, in that case, that's where you can appreciate that there's clear oligohydramnios. And on the right, with the membrane folding, it looks a little bit thicker than you would otherwise appreciate. It's very easy to discount and measure the fluid above and the fluid below and call it normal. So this can be referred to as the chandelier sign. So be very clear that you appreciate the membrane between the two and do not miss abnormalities of amniotic fluid. Number 6, when evaluating Dopplers in the umbilical artery, or actually any of the arteries or vessels, proper technique is absolutely essential. So in the first two, if you have a large sweep speed, you may identify that there is a fixed pattern, either normal, for instance, absent or reversed end diastolic velocity. But in order to really appreciate and assess what is the true pattern in the umbilical artery Doppler, in this example, it is important to narrow your color box to optimize your picture and your frame weight, get your intonation angle as close to 0 as possible, adjust the wall filter so you do not lose the baseline, and slow the sweep speed so you can really appreciate the potential fluctuation in the umbilical artery Doppler pattern. Now, this is most important in evaluating cases of SIUGR. And what you can appreciate very clearly is that particularly when there's a large artery-to-artery anastomosis, you can often find it on the placenta. And so just following the cord insertion out, you can see it both on color Doppler in this example, and on the pulse wave, you see the rapid oscillation between the twins on that vessel. So, so pay close attention with your Doppler technique. Number 7, TAPS can occur with normal fluid and bladders. And this is a case that was referred to us not that long ago, but for concern for discordant fluid. And so we have normal fluid, although discordant, between the twins. Both have a normal bladder. And you may appreciate there's a little bit of ascites on in the lower image. However, the key feature on this example that can also clue you that you may have TAPS is the discordance in placental echogenicity in the video. And so one side may have a very thick and echogenic placenta, the other one may be thin, and typically that vascular equator runs right along that line. And so this is a classic image when you're scanning a patient. If you see that difference in echogenicity, think TAPS. And this can also occur normal fluid, normal bladders, normal umbilical and ductus venosus Dopplers, and you must check the middle cerebral artery peak systolic velocity. And so in this case, there was quite discordance on that first one. And as we discussed, this is also one of the complications we're watching for post-laser, typically as a result of that single vessel hiding right behind the entry, as shown in this video from a previous laser. And so even primarily in TAPS cases, laser can be curative as well. Number 8, severe TTTS can also exist with normal fluid and bladders. So this was a case that was referred to us for stage 1 TTTS. And in fact, at this point, fluid criteria was met on the outside, but when she arrived, the first question, is this a case that's actually stable and improving? So there is discordant fluid, not meeting criteria, normal bladder filling for both twins. But when you're looking a little bit more closely, you notice very significant cardiomegaly on one fetus compared to what should be normal. Putting on the color, you see massive valvular regurgitation. And looking a little closer, there's also high drops of one baby, so with normal umbilical artery Doppler. Now, this case also had umbilical venous pulsations and a reverse ductus venosus A wave. And so this presentation is actually severe TTTS, but more likely either rapid onset or decompensation. And so again, in this case, this treatment was laser with good resolution. Next, this is, I think, one really important thing to appreciate and recognize. In cases of single fetal demise, you cannot rely on the middle cerebral artery peak systolic velocity to be reassured that there is not co-twin compromise. So this particular case is a patient where single fetal demise was actually identified on the screening, on the ultrasound at the time. So we know exactly when this occurred, bradycardia to asystole. Now, in short interval follow-up, 2 hours later, there's still normal speed in the middle cerebral peak, middle MCA peak systolic velocity. However, because of recognizing the timing of the device, in this case, we had set up for rescue transfusion and cortocentesis. And in fact, the opening hemoglobin was severely low at 8 grams per deciliter. Now, this is a pre-viable case. This was observed, so the management of this situation may be a bit controversial, but even immediately prior to cortocentesis, this value was normal. And also after transfusion did not change very much. And so this we have observed, sadly, several different cases, but the findings have all been the same: severe anemia and normal middle cerebral artery peak systolic velocity. So if you identify this early, the management is certainly challenging, of which to manage expectantly or intervene. But if you are past the time of viability, I just request that you extend your monitoring for a period of time and not send that patient home, because you may see signs of fetal distress rapidly in a short time interval. Finally, big things don't grow. If you see something in the first trimester that looks like a single fetal demise, it is a trap, especially when it's getting bigger. And so the thing that you must notice is that you measure that small CRL, everything looks fine, single fetal demise, you counsel the patient. When you put the color box on, extend it to the cord, because you may see that inside the fetus, you see no color flow, but the cord is still showing you reverse perfusion. And then you're sad several weeks later when that blood flow looks even more substantial and very high velocity with a nice normal reversed umbilical artery Doppler pattern. And at that time may turn into signs of co-twin compromise and actually require an ablation technique. So do not get surprised in the second trimester in these cases. So finally, comprehensive assessment of monochorionic twins is absolutely critical. Every evaluation, please consider the entire spectrum of disease, and that will ensure the best safety as possible for these tricky pregnancies. And I thank you very much for your attention.
Thank you, Gina. That was beautiful, and I love the way that it was documented, and you presented in a very smooth type of way, very common situations that we might encounter whenever we see a lot of monochorionic twin pregnancies. I think it was very clear. So we can start with some of the questions that were in the Q&A box. I have a question for Shami from Dr. Luc Joget. Hi, Luc. Do you have any experience of TTTS treatment for anterior placenta with a flexible scope? Shami, do you want to explain for the not so experienced audience what he's talking about a little bit?
Luke, that was a great question. For audience, the scope that we use is a semi-rigid scope, but there are some flexible scopes that you can use it in the, other places in the medicine, such as your endoscope that you're doing for endoscopy, or you can use some of these your urology scope. Outside of the United States, yes, I've done. There's two questions and two challenges that is coming down to this flexible scope. The first, challenge is usually you had a flexible scope. You put this flexible scope in a polyhydramnios situation. Therefore, the orientation is not that easy. That means you see it and easily you can lose that orientation. With that said, we make something like metallic, small tube that you can tread down this flexible scope, and that will help you with the orientation. However, the issue with that is when you're moving around that flexible scope, because the cover of this flexible scope majority is plastic, you can start disturbing that plastic and destroy your scope. And these are very expensive scope. When I destroy a couple of them, the bosses are not happy, therefore I stop. But again, I think there's a place to definitely more investment, and I think definitely that should be the next answer to this question of this flexible scope. And even with the flexible scope, maybe you can use a much smaller scopes than what we are using now in the fetoscopy laser.
Thanks for the answer. That was very clarifying. Julian, there's a question from Sofia Cordova for you. She's asking, would you consider to do a prophylactic laser ablation in a patient with Quintero stage 1 TTTS if the patient is unable to come to the hospital for weekly follow-up?
Yes.
Yeah, I think that it's important.
Definitely. Yeah, of course. Of course. I mean, you can postpone surgery and try to see if she's going to be stable only, and if only she will comply with a weekly follow-up, and that she agrees with the possibility that it does progress, sometimes to a stage 3 or even 4 quite rapidly. It occurred maybe once or twice, and I remember that it did progress a little more rapidly than I expected, and sometimes we did have demises, huh? So that can happen. So she has to comply with the project, with the probabilistic aspect of things, and with follow-up, obviously. Yeah, and she has to have a long cervix, no contractions, and so on and so forth. Obviously, she has to be asymptomatic and comply.
Thank you. I think that we all agree on that. Dr. Carolina Adam has a question for Dr. Miller. So she's asking if you could speculate why MCA is normal in severe anemia in the post-co-twin UFD period.
I have thought about this a lot, and I just wonder if, because it is such an acute event, that you don't have your normal compensatory response as you do for other cases of progressive or element of slower fetal anemia, such as, an RH disease. So I think this is just such an acute event that the fetus doesn't have the opportunity to mount that response. And we've seen this several times, and I wish I had a perfect explanation to understand why, but this is, an observation that we've seen. I don't know if anybody else has any ideas.
Gina, can I ask you that question? That means, from my understanding is you're proposing that on a monodiet twins, if you end up with a one IUFT or sudden death, then it's better the next step do the POP. Or
I think we actually looked at this data with several different setters, and I think that it's not exactly clear what the right management is. I mean, this is a challenge no matter what. In cases where we have them pre-viable very early in gestation, we've had experience going both ways. So corticentesis and fetal blood sampling and transfusion, both the data is split. Half the time they're going to do fine, half the time you still have a co-twin demise. So I'm not exactly sure what the right strategy is, but these are extremely sick fetuses no matter what. And the only time that we've actually done any sampling is when we know exactly, like, the demise is observed, or that it's such a short interval. If it happened, your last scan is a week ago and you come in, a baby looks well, then there's nothing to do, right? Just pray. And but in these cases where exactly when the demise happened, it's very challenging to know what to do. However, after viability, those are the ones that you just cannot send home from the unit. That you see a demise, the other baby looks well, normal MCA, normal biophysical. I mean, we had the same case last week, and the baby was delivered in stat section in 2 hours and required blood in the delivery room. So this is something that you just cannot be falsely reassured is the most important part when you find that value to be normal.
Julian, what is your approach in France?
Regarding, I'm sorry, can you hear me? Yes. Regarding the issue of MCA PSV and acute fetal death. Yeah. Well, that happened. I mean, I know that situation also. I only know it from patients that you hospitalize for a surgery on following day, and when she gets to the operating room, you scan her just before you put the scope in, and that one baby's dead. So that's really when that's the main situation I can remember where you can actually witness that the baby was alive a couple of hours before and he's dead when he gets to the operating room. And in those instances, yes, it does happen, and it's actually very frequent that MCA PSV is not only is it not increased, but it can be actually very low. You just sort of see a twitching of the MCA PSV on the Doppler line, and so do not be fooled by that, because they can be very very anemic, and we transfuse those babies immediately. We don't deliver, obviously, even if they're viable. We transfuse and you follow up.
Great, thanks.
I would like to, it's almost 11 a.m. here in Houston time. I would like to thank all the speakers for beautiful presentations. I would also like to thank all the participants for being there and for registering to this webinar and for your questions. I would like to introduce the next webinar that we will have. It will continue on the same topic on complicated monochorionic pregnancies. It will be on September 25th at 9 a.m. Central Standard Time, and we'll be talking about laser treatment for selective fetal growth restriction, what to do when you have both diagnoses of selective fetal growth restriction and TTTS, and how to manage TRAP sequence and TAPS. It will be the same procedure that we have done for this webinar, so you would have to register in advance. If you want to have access to the video of the recording of today's webinar, it will be here. This is the same website that you access to register. It's right at the bottom of the agenda of today's meeting. So that way you will access to the YouTube channel that we have, and in like maybe 1 to 2 weeks, the recording will be posted there. Shami, do you have any final remarks that you would like to do?
Oh, again, thank you very much for all the speakers. It was a great job, and thank you everybody for joining us. I do see some questions that is left. Unfortunately, we don't have a time to answer now, but I promise you guys that we will send an email to each one of you regarding your question and try to answer them appropriately. Thank you very much. Have a great weekend, and hopefully see you next month.
Thank you.
Thank you. Thank you very much.